Well, good evening, everybody, and a very warm welcome to our community focus webinar tonight, which is focusing on children in a time of COVID, and particularly at this time when children are going back to school. I'd like to start by acknowledging the traditional owners of all the lands on which we meet tonight, and to pay our respects to their elders, past, present, and emerging. So tonight we're going to have a brief overview of what we know about COVID in general, about the new coronavirus, and then have a bit of a deep dive into its impact on children and how we as parents and community members manage this in our communities. Next slide, please. I'm delighted tonight to welcome Vanaja Sabesan and Andrew White, who many of you will know, preeminent paediatricians based in our region, really understand Queensland and North Queensland and particularly understand children. And so without further ado, we'll go to the next slide. And I think, Vana, we are starting. Oh, no, sorry, before we go that, just to let you know that you can't use chat. But if you have any questions that you'd like to direct to the panelists, if you could just use the Q&A button at the bottom of your screen there, I'll be looking at the questions and we'll give them to Andrew and Vana. Thank you to those of you who have submitted questions, and Andrew and Vana have tried to incorporate the answers to their discussion in their talk, but obviously if it doesn't completely meet what you were hoping and there's some details that you would like further from them, please go ahead and use that Q&A function. Right, next slide, please, and over to our presenters.
Thank you, Piran, for the lovely introduction, and thanks for those people who have logged in and will be watching this presentation later on. So I guess what I'm trying to do initially, try to give a bit of an overview of what this coronavirus is, and be interchangeably using COVID-19 and coronavirus, and then talk about how does that affect the children, and we talk about the evidence we have, and at the end how we manage this getting children going back to school and what we can do to help them. So with that, coronavirus, as a lot of us know, different types of bugs we talk about, bacteria, viruses. It belongs to a virus. It's a coronavirus family, and I won't use that Latin word for that. It's hard enough for me, and it's hard enough for everybody else. So the group of coronavirus commonly affects children, and they can have some just a mild respiratory symptoms. That's the usual coronavirus. But we have had recently in the last decade, there are types of coronavirus that cause quite significant disease in children, in adult population and globally, and in children, of course. You might have heard of SARS, basically meaning severe acute respiratory syndrome, which sort of came in early 2000, around 2002. That caused a significant problem. And then we had Middle East respiratory syndrome, which is about in 2012. They all belong to the same group of coronavirus, but obviously their genetic material is a bit different. This picture looks quite pretty, doesn't it? But this is a good example of you don't judge the person by their look, because this virus has caused so much harm to the world population at the moment. What do we know about this virus? It can't really survive in the environment forever. So meaning that from person to person, it needs to go to cause disease and survive. So usually we know there's an animal host and human, in particular coronavirus. There was a lot of discussion about where this came from. We won't go into that. I'm sure you have read quite a lot of information on that already. After we expose to this virus, adults or children, it may take up to 14 days to develop symptoms after being had a significant exposure. So that's one of the reasons we have that 14 days quarantine period. But we also know most of those children and adults exposed to this virus will develop symptoms in the first 4 to 5 days. Next slide. So we talk about all this social distancing and physical distancing, hand hygiene. Why do we talk about that? It's because we know how the virus goes from one person to other person. The common form of transmission. It's called direct droplet. Basically, if you are in close contact with another person between 1.5 meters to 2 meters distance, by coughing, forceful coughing, sneezing, even talking onto their face, it can, and at the time, if you are got the disease, it can go to the other person. But the other way it can spread is after somebody had a really bad coughing spit, and then they cough the droplets onto the surfaces, and another person passing by touch the surface and touch the face, nose, eye, they can get the disease from that too. So that's the reason we talk about hand hygiene and physical distancing as an important aspect in containing this virus. We also know after it's sort of exposed on the surface, if we don't disinfect the surface, it can last up to 6 to 9 days. This is after they went around and swapped all the surfaces. This is what they found, the scientists. But we know it's not significantly got the viral load at the time. Basically meaning it's not that infectious as it is in the first few days, for example.
Vana, can I just double check that with you? So say someone's had a big, and I'm thinking particularly of schools now, because I'm sure we've got a lot of teachers and parents thinking about it. So say, unfortunately, someone has been to the school and they've coughed or sneezed and it's gone onto a desk or chairs or surfaces. What I understand from what you're saying, although there may be a little bit of virus still present there several days later, because you may have just missed a little bit when it was wiped down or something, that bit of virus isn't necessarily as infective at day 6 or 7 as it would have been within the first couple of hours. Is that correct?
That's exactly right. So I guess scientists went around and did the swabs, and that's what they found. But the answer to your question is that's correct. So so even if you miss a little surface, it's not going to be major deal, but we aiming to not to miss the surface. When we found out somebody had a COVID in the school environment or any environment, that's one of the reasons public health officials close down the classroom, sometimes close down the schools and do this big clean. That's the reason.
And obviously if we wash our hands regularly, then even if we touch the surface and it got on our hands, then that's the way of doing it. Thank you.
Yeah, that's main reason the governments and all the public health officials talking about keeping that 1.52 meter distance, because that's going to be really important for us to keep doing that, even though we have a good chance that it has been really good for us. It's so important to continue to do that, and doing personal hygiene, hand washing, sneezing in the right, coughing, sneezing into the elbow and the tissues and so on. The other way we postulated in epidemiological sense, it can spread through airborne. So for the community is not a big deal. So healthcare professionals, obviously this is one of our major issues. So when we are doing procedures on people, looking into their throat and giving nebulized oxygen, high nebulized things like ventilating or other procedures like intubating people, we are at high risk. And that's one of the reasons healthcare officials are recommended always to use personal protective equipment versus the community members. Next slide, please. So the question in our mind, can children get it? Initially, there were some reports saying, oh, look, children they are not getting as much as adults. That is true. But from the studies published in children worldwide, including in Australia, yes, the children of all ages can get it. But the good news is for children, depending on the studies you looked at, 1 to 5% of total cases of COVID contributed by children, which is a great thing. If you look at the world population, children contribute to the world population quite a lot, and if they're only getting 1 to 5% disease, which is really good for children. And then other thing they found, importantly, those children who are affected, most of those studies saying the children came from the same household of an affected adult or family member. So which is a good news. Not all of them, but most of them. And we have proven over and over again, children to children transmission and children to adult transmission is very, very rare. So which is really good, important thing for us to consider when we are getting the children back to school. Next slide.
So gosh, Vana, before we go to the next slide, sorry, Erin, can we go back? This is really interesting and very important, isn't it? Because it's very different to what we would experience, for example, with influenza or with rhinoviruses, some of the other viruses, where children are like viral torpedoes, aren't they? They just transmit and they're full of it. But this is significantly different. And what I'm particularly interested in is that the children to adult transmission appears to be very low, which would be of reassurance on return to school, wouldn't it? Because if you're a teacher or an adult in that situation, you would be concerned, wouldn't you? But from what you're saying here, the emerging evidence is that it's not a huge concern. Is that correct?
That's exactly right, Peter. And that's Andrew will talk about a study that published recently about that particular issue later in the presentation.
Vana, do we know why? Is there any more than just speculation about why this virus is different in this way?
Well, very interesting theory. So I don't know whether you remember the first picture I showed to you. That's got the little spikes, and what we know so far about this virus, there's a particular receptor we have called ACE2 receptors that a lot of adults with hypertension, and we know that's kind of, we do block that receptor to manage the hypertension. So this virus needs a receptor to gain access or entry into the cells. And there's a postulated that children don't have that receptors as adults. That's one theory that may be the reason why children are not affected. But also the other one is coronavirus, the other type of coronavirus. As I said, coronavirus is a big family, and COVID-19 is one of them. That sort of a common cold causing coronavirus, the children may have some antibodies in their system protecting them. So it's all theories. We don't know exactly the reason, but we know for sure that children are unaffected and not transmitting as adults.
So interesting. And Vana, just a really quick question that's come from the audience, which is very interesting. What age range, when we talk about children, how far are we going up to? Is a 16-year-old included within children? Or
no, so when the studies published, they're kind of talking from primary school to 13, 14 years and senior school children. So they're kind of separating it. There's some difference in presentation as you grow older. So we are talking about children up to that age, but even that younger senior school students are still, could be treated as children, but it's mainly sort of primary school up to about 14, 15 age group.
Thank you.
Andrew, did you want to comment on that at all at this point about the age group from your experience?
Well, not from my experience, because I haven't seen any cases in North Queensland, but the suggestion is younger children are much less common, and children older than 14 behave more like adults.
Yeah. Next slide, please. So now let's look at what's the disease in children. So are they presenting differently to adults? And the studies published so far, they're finding about 3/4 of children had one or at least one of those three symptoms that commonly occurs in adults, like cough, fever, or shortness of breath. Those are the main three symptoms we talk about in the adult population. And this 75% of them, if they have any symptoms, they have one of these symptoms. The other 1/4 of them, they don't have any symptoms at all. Then if you break it down the symptom wise, what is the commonest symptoms? It's not a fever contributing up to about 60%, cough in 54%, shortness of breath of 14%. So it's kind of not many symptoms as in adults. And I guess if we just specifically focus on children in Queensland, and we haven't had very many kids in Queensland, particularly in Townsville, and they haven't been that sick. So they may have been admitted because initially we were cautious about admitting children, but none of them been sick. So which is a great thing for children. Next slide, please.
Vana, just before you do, because I think this is something that really puzzles everybody, the asymptomatic person. I mean, I think for as doctors, it's pretty hard for us to get our heads around that. I think for community people, we're going, how can they have this virus and they know nothing, and can they transmit it? Do you, Andrew, have any views or comments on this at this stage?
So if you go to the next slide, I can there's another information about the disease presentation. So you can see from here, vast majority of children, like 81%, they have no or only mild symptoms. So they might have a mild cough or mild fever or mild shortness of breath. It's nothing significant at all. So why is it in children? It's hard to know because, the children don't seem to have severe disease as the adults. Did I answer your question, Peter?
Yeah, I think so. Thank you. And also, I was answering a question while you were talking. Someone wanted to know if we're talking just about evidence that's come nationally and internationally, and what I said is actually this is emerging evidence internationally.
That's right.
So it's everything that's kind of China, Singapore, Europe, USA, as well as some of our local studies. Is that correct?
That's correct. So, initially we only had studies from China, and then we had more studies from UK, particularly in London. And then we had further studies from Italy, USA, Netherlands, and recently from Australia as well. So emerging evidence, as we need to emphasize these things are changing as we talk about it too. Like how we felt about this in Australia 4 weeks ago, different to what we are feeling now. And there are more evidence come through. So things will change, and we will keep continuing to update ourselves and give the right advice to the community, I guess.
Thank you. There's a lovely, sorry, Andrew, go ahead.
So I was just saying, I think the point about a lot of people having really mild symptoms is important, because it's important for us, all of us and children now, if we have mild symptoms, that we should stay home from work, we should get tested, because it probably isn't coronavirus, but it could be. So that point about lots of people having very mild symptoms, I think is really important to remember. And, our usual thing is we soldier on if we feel a little bit sick, but today and this next few months, we probably should stay home and see a doctor, get a test.
I think that's such an important point, Andrew. It's really going to change the way we work, because I think a lot of people have very strong work ethics, and we're pretty stoic, and we say, oh, I've got a bit of sore throat, a bit of a sneeze, a cough. Those days are gone, I think, and they may be gone for a very long time. Can I just ask you, there's such an interesting comment here. John Otto says, children are generally fitter than adults. Do you think that this has got any impact on their exposure to COVID, their experience of it? Do we have any answers to that?
I don't think so, because we know children are generally fitter than adults, but a flu gets them really badly. So I think it's something about this virus and their interaction, how that enters the cells and so on, something to do with it. And hopefully we will have more evidence of why soon. I told you about a couple of reasons, but there might be more coming out.
There is a bit of stuff in adults about being overweight being a risk factor, I suppose. I don't know if it's being unfit. It's probably being overweight more than being unfit, I think.
And my reading of that, Andrew, is because if you're carrying a lot of extra weight, to actually ventilate your lungs, to breathe in and out, can be a lot harder. And then particularly if you're sick, I think I was wondering about that. Andrew, there's another question here, which I think you're going to talk to in a minute, but it says, what actually is a deep clean? So are you going to talk about that when you talk about keeping schools safe, or?
Well, I was going to say deep clean, but what is a deep clean? They always say it on the news.
They do.
I would have to ask a cleaner what that is, but I guess it's cleaning really deeply, really well.
My understanding is that it's sort of the clean that you would do if someone has been very, very sick in your, like they've been vomiting everywhere, and it's every surface, it's every high touch point, it's every little nook cranny that you can get into, is you use a chlorine-based or a bleach-based cleaner. That's what I understand.
That's what I think. Every night the cleaners might come around, they clean the floor, but they wipe off the desk if it looks dirty. But a deep clean would be
every surface.
Cleaning every surface, every area that they can.
And then using
sorry, and we're not going to get off this slide. Oh, someone enjoyed your comment, Andrew. The question here is the low transmission from children to adults due, do you think, to the low percentage of cases in children, or is it because they don't transmit it?
I don't think we know. I think low rates of infection is one thing, and perhaps those who do have mild symptoms, maybe they cough less number of viruses, because certainly the dose of virus that you get is related to risk of getting infection.
So what you're talking about there, Andrew, is viral load, aren't you? So we know that if someone is very ill, they've got a lot of virus and they cough at you or you're in contact with them, that's a far riskier situation than someone with mild disease who may really, not be shedding very much virus at all. And so what you're saying is, our understanding is, because children are often very mildly affected, their actual transmission of virus is probably very low as a consequence. Is that correct?
I think that's right. And for example, in some of the hospitals in the US, for example, doctors who've been looking after very sick patients who are coughing up a lot of virus is probably the reason that those staff have had higher rates of infection as well, because they're getting exposed to a lot of virus, not just a little bit of virus.
Thank you. And the last thing I wanted to ask you, and then before we go on to the next slide, I'm very interested in this disease severity, the 80%, 14%, 5%, because that is very similar, in fact, to the adult rate, isn't it? That most are very mild, about 10 to 15% quite sick, and then 5% critically sick. So of the children who get it, it's a very similar pattern, isn't it? Have you got any comments on that?
Yeah, I think a similar pattern, but then you need to remember, as we said before, it's only 1 to 5%, depending on what study you look at, are contributed by children. So I guess in Australia, we are testing so many of them, mild symptoms, and we've got extensive testing capabilities. But the studies from USA, maybe they are underestimating this non-asymptomatic and mild symptomatic children. So I guess that's kind of an answer, even though it's the same, the proportion, but children are contributing only smaller percentage for the whole thing.
Yeah, thanks. And here we've got a very helpful comment from someone who said, we had to do a deep clean after a gastro outbreak at kindy. And it is, as you described, plus curtains, mats, all toys, pens, books, etc. So basically everything that was in that vicinity. Yeah. Right. Thank you. Let's keep going.
Excellent. Next slide.
Oh, this is my slide. I guess you've probably all seen lots of pictures like this every day if you look at the news. For me, I may be a little bit weird, but I quite like graphs. So that's been the one positive about coronavirus. I won't go too far into this, but just really to say that if we're thinking about children going back to school in Queensland, in Australia, our situation is quite different than it is in a lot of places in the world. We're probably in one of the luckiest places in the world. And you can see the black line is Australia. So over the first days of the epidemic in Australia, we had lots of cases appearing, but then over the last month or so, we've had very few new cases. And in fact, I think Queensland, the last I saw, we haven't had any new cases for several days. And Australia as a whole is having about 10 to 20 cases, new cases each day, mostly in Victoria or New South Wales. That doesn't mean to say there's no virus around, and we could have little breakouts even in North Queensland as we go forward, but it is quite a different situation. And if you look at the up and down axis on this graph, that's a logarithmic scale. So every line, it's 10 times higher. So the US, for example, has got over 1 million cases, whereas we've got about 6,000 to 7,000 cases. So much, much lower and much less in the community. And the other thing is, the reason we know how many cases we've got is we've got a good system of testing, and we've got a good system where we follow up and we contact trace for all the contacts of people who've been tested positive. In a lot of the other countries, their rates are probably a big underestimate because they've only tested people who've presented being quite sick. So that's really just to say our rates as we know, are really, really low compared to a lot of places. So the data we see from the UK, the US, Europe is quite different to what our situation in Australia is at the moment. Next slide. And this is just Australian data. It's just to show the distribution of cases by age. So you can see in Australia, there's between 6,000 and 7,000 cases have been diagnosed. And of those, only 41 are less than 10 years of age, and 107 between 10 and 19 years of age. Actually, I think that's the males, and there's a similar number for females as well, but a very small number in the child age group.
And that really, Andrew and Vana, that really illustrates what we were saying earlier, isn't it? Australia has this extraordinary good testing system. We have a very low detection rate in our tests, which means that we're doing enough tests to pick up community transmission. And despite that, the numbers in children are really, really small, aren't they?
They are. And I think our advantage is because our numbers are really low, it means every new case, we've got public health staff who can do very intense contact tracing for all of those cases. If we had 1 million cases, the system would be swamped and we wouldn't be able to contact trace very well. Next slide. And this is actually an older graph, but again, it's just to illustrate, this just shows mortality rates or fatality rates by age. And it's just to show that the mortality rates are really concentrated in people who are in their 70s and above, or 60s and above, with some in younger age groups. So it's not to say that young people are immune and can't get sick or can't die, but children are even lower. On this early data from Spain, China, and Italy, there were no young children who've died. But since then, in the UK and the US, there are a handful of child deaths, but extremely low. And I think putting it into context, you know, the number of children who've died in the US from COVID would be less than the numbers that would die in the US annually from influenza in a normal year.
Yeah, we were talking about this earlier, weren't we, Andrew? And you and Vana were saying, as far as you can see from the case reports that are coming out of the US and the UK, that a percentage of those children who very sadly have died did have other health conditions. Is that correct?
Yeah, so some of the children had other conditions, so chronic lung disease or some immune deficiency or something else, heart disease.
Cardiac.
But some of them also had no known risk factors. And I suppose that is what we see with influenza as well. Every now and then we see a young child who gets very sick from influenza and they don't seem to have any particular risk factors. It's very unusual, but it happens every now and then. And
I suppose it's such a fear for parents, isn't it, that something could make your child...
It's a tragedy whenever it happens.
That's right.
And so it is for every dot on this graph is a tragedy for the family of that person.
We've just had a question come in about the Kawasaki-like disease, but I know you're about to cover that on Tuesday.
It's about to come,
yeah.
We could go to the next slide if you want to.
So we keep talking about vulnerable children and children at high risk of having this disease. And I have listed a few of those conditions and the age group that's been published in the literature. Almost all of them did from this year. But the important thing for us is these are the children from communities like USA and UK and China, where they had high rate of community spread. So I think that's an important thing to remember. And in Australia, we have very, very, very low community spread at the moment. So from there, so children or infants of less than 1 year of age, any children with chronic lung disease, like I'm not sure whether you've heard of cystic fibrosis, and if they have severe asthma, so in my general pediatric experience in Townsville for the last 20 years, and we don't see that very many severe asthmatic children here at all. And immunosuppression, children undergoing chemotherapy who had bone marrow transplant. So now in overseas recommendation, they are grouping these children as high risk group, but we know from our data in Australia, so Australia and New Zealand data, we are saying that's not a major risk factor at all. So if your doctor told you before COVID time, say in sort of end of last year, that you could go to school when you're undergoing immunosuppressive treatment for childhood cancer or renal disease or anything, that's still okay now. So basically meaning that recommendation hasn't changed in Australia. Obesity is sort of a marginal risk factor. We talked about that earlier in adults. It might be related to the associated cardiovascular risk factors or difficulty ventilating them and so on. But in children also there is a marginal risk for those children as well. But that particular data actually came from China, so it's hard to know, you know, a lot of children, the obesity is not a major problem, so I'm not sure how reliable that is. Definitely diabetes and chronic kidney disease, but I just can't emphasize enough, this is for countries where we have high community spread. And Australia, we don't have that. So initially, for example, we recommended our oncology children and their siblings not to go to school even before the school shut down, but we are really happy now for them to go back to school. Next slide.
Thank you. No, Vana, before we move, a couple of things. We see, as you know, a lot of asthma, kids with asthma, and I know that there are some parents who are just terrified about this, about the potential impact on their parents, on their children. Would you mind unpacking for us what you mean by severe asthma and yeah, so paint a picture for us of what those children would look like and how that might compare, say, to a child who might get a bit of asthma post-virally or some exercise-induced asthma?
Yeah, when we talk about asthma, we categorize them, as you said, mild to severe. So when I said we don't have very severe asthma, meaning that we hardly get children repeatedly getting admitted to the hospitals or intensive care with asthma. So when we talk about severe asthma, we are talking about those group of children who are on maximum dose of preventive treatment like Flexitide or Pulmicort or things like that, and still needing lots of prednisolone repeatedly to control their asthma, and they keep coming to the emergency department and getting admitted to the hospital and ending up in an intensive care unit. So this is a group of children we are talking about. We're not talking about the kids that you will see in the general practice with sort of mild wheezing and asthma symptoms after having a viral infection or change in weather. We are not talking about that group of children. We are talking about children who got really needing a lot of treatment and ending up in the hospitals all the time. So does it explain that well? Yeah.
That's right. We have a question as well, which is very relevant. Is, in your view, or as far as we know, are Aboriginal or Torres Strait Islander children be more vulnerable to the disease? Do we know?
That's a very important and a good question, especially in North Queensland. Andrew will help me with that too, but generally we find children with Aboriginal and Torres Strait Islander background, they have other associated condition. Unfortunately, we have high risk of rheumatic heart disease and so on. So they're probably, in comparison for a 10-year-old non-Aboriginal Torres Strait Islander child, they might be at a little bit higher risk, but it's because of other associated risk factors and their well-being and their health and all of those other things. Andrew, do you want to comment on that too?
Yeah, I think number one, we don't know because fortunately the disease hasn't reached our Aboriginal and Torres Strait Islander communities. Secondly, I suspect it's not a genetic reason. If there's a higher risk, it would be related to rates of other underlying chronic illnesses. And thirdly, it's probably for adults in those communities, we know there's higher rates of things like chronic obstructive lung disease, diabetes, chronic kidney disease. So it may be that adults in those communities are certainly likely to be at higher risk, but children may not be, or maybe a little bit higher risk. We don't really know.
Thank you.
But we don't really want to find out. So we
don't. Absolutely.
It doesn't get to those places.
Yeah.
Here's a very interesting question. Would a child with anemia, who obviously, when you're anemic, you might be a bit short of breath at times, would we consider them a high-risk individual?
No. But having said that, if they get the disease and if they're needing support and so on, we know when it comes to treating children with anemia can be a problem, but obviously that can be corrected. So I wouldn't think that as a risk factor.
All right, so we're getting lots of questions in. I might let you keep going with your slides for a little bit, and then we'll come back to some questions.
Next slide.
So Kawasaki's disease. I thought we should talk about this because this has come up in the media recently. And we know that the first first of all, Kawasaki's disease is a condition that it's rare, but it's not all that rare. For example, in Townsville, we would probably see 2, 3, 4 cases maybe every year. It's usually younger children. We don't really know what causes it, but it may be triggered off by a preceding viral illness, and they present and they have, they're unwell with fevers for a number of days. They have conjunctivitis, they have a red swollen tongue, they have a rash, they end up with peeling hands and feet. And the complication they can have is that they can get dilatation of their coronary arteries, and we can treat them with gamma globulin to prevent that from happening. So I just mentioned that so that people probably are not really aware of Kawasaki's disease because it's quite uncommon. In the UK, they reported 8 children in London who presented to hospital and they had features of Kawasaki's disease, but they were also very sick. They had shock and they needed support in intensive care. It's not really clear whether it was directly related to COVID infection or not. Certainly they came in at the same time. I think only about half of them had tested positive for coronavirus. Subsequent to that, more reports have come in of other children in the US and the UK, where there have been huge numbers of children infected with coronavirus in a population where a huge number of people have been infected with coronavirus. We don't really have the studies of what's happened with these children and whether it's caused by coronavirus or not. We don't really have those studies. There's been some reports of cases, but studying those cases and reporting them in a scientific way hasn't really happened yet. So it's certainly something to look out for. The best I could find was a specialist from Sydney, Professor Boy, who said he thought it might be that 1 in 10,000 children with coronavirus might get Kawasaki's disease. And as Australia had less than 200 children who'd had the infection, he thought it would be very unlikely to see cases or very many cases in Australia at all. And he wasn't sure if, from what he'd read, whether it was a link between coronavirus and Kawasaki disease, or if it was just an overlap in numbers so that a few children who were going to get Kawasaki disease anyway also had coronavirus at the same time. So we don't know too much. It's extremely rare, even in those other countries. And because our numbers are so low, we would expect it would be extraordinarily uncommon to happen in Australia, but not impossible.
Thank you, Andrew. And this circles back to what we were talking earlier, and there's a very interesting comment from one of the participants saying that a lot of commentators have been making uninformed comments, for example, saying, oh, this is just like the flu. But obviously, there are lots of unknowns with this novel coronavirus, aren't there? And this person has asked, in your opinion, what are some of the unknowns at the moment with this novel virus?
I guess the big unknowns really are what's going to happen in the future. We don't know if people who've been infected develop immunity. We think they do, but we don't know if that might last for a few months or whether it lasts a long time or whether it's lifelong. We don't know if there'll be a vaccine. We don't know if there's long-term issues for adults who've been infected. We don't know if there's other issues that could pop up in
okay, that's enough don't
like
knows. That's enough don't knows.
Yeah, lots of don't knows, yeah.
And to add to it, and we are finding more and more about this virus as the time progresses. You know, the amount of information we found out about this in the last 3 months is phenomenal. So I guess that will add to our evidence as we progress through it and learn from other countries. And fortunately, we don't have to learn it in Australia, hopefully. And hopefully we can continue that.
And just one other question, and I think this is a very interesting one. How you may be coming to address in a minute, but how do children and teachers cope with going to school where they feel pretty safe? And we've discussed, you know, transmission isn't very high, but they are going home to vulnerable parents or to elderly parents. So for say you're going home to a parent who does have severe asthma or someone with diabetes, what would your thinking then be about those children being at school?
We could answer this now or wait till we talk about grandparents and what do we do with grandparents and so on, or do you
right, maybe wait till then and then we can see. Okay,
yeah.
Go.
So maybe the next slide then, Peter. So this is just about safety of returning to school and what evidence do we have. I'm just going to show you in a little bit of detail a study from New South Wales, which is probably the best study we've got. I looked at this study, it came from last month, and I thought there must have been better studies done in the US or the UK or somewhere since then, but I can't find anything. And when I think about it, I guess I realize why, because it's very hard to study this in a country where there's so much coronavirus in the community that if a child gets coronavirus, you wouldn't know whether they've got it from home, from school, from the bus, or from someone they've passed in the shop. Whereas in New South Wales, when they studied this, it was when there wasn't much coronavirus in the community, but there were a number of people who were identified in schools in New South Wales in April and early March. So in this study, they looked at 18 people, 9 students and 9 adults who were going to school in New South Wales. The adults, I think, were the teachers, and they had coronavirus diagnosed. They followed up all of those individuals with coronavirus, and they identified all of their close contacts. So they identified 863 people who were close contacts of those people in the school with coronavirus.
Andrew, it might be good to talk about what is close contact here. The close contact meaning
So the close contact in this situation was 15 minutes, more than 15 minutes of face-to-face contact. So that's like less than a meter, less than 1.5 meters for more than 15 minutes, or more than 2 hours. Sorry, more than 15 minutes, or more than 2 hours of being in the same room with that person. So it's sort of like a typical school situation. And then they followed all those close contacts up over the next weeks. They did enhanced surveillance, so they got them to fill out a diary every day to see if they had symptoms. They swabbed them to see whether they had coronavirus, and a little bit later they did antibody tests. And then this next slide, if we could go to that one, shows the results. So if you get your head around this little graph, this is just the results for the 10 high schools. And if you look at that, each block of little people there represents each of the high schools. The little people at the top in the circle are the cases in each of those schools who had coronavirus. So you can see the top left school, there were 2 children in that school who had coronavirus. And then all the green people and all the blue people in the block underneath are all the people who had contact with them. And the green people are children, and the blue people are adults who had close contact with those individuals with coronavirus. And you can see the same thing for each school. The ones with the little circle, the person in the circle at the top in blue, they're adults who were in the school with coronavirus. And what did they find? They found out of all of these students in all of these schools, there was just that one little red one at the top left-hand corner, that one child who most likely caught coronavirus from being exposed at school, and nobody else did. I haven't shown the primary schools, but there were 5 primary schools in this study as well, and it had pretty much exactly the same result. In that cohort of 5 primary schools, there was one child who likely caught coronavirus at school, and there were no adults and no teachers who contracted coronavirus at the school.
But that's quite extraordinary, isn't it? And really bears out what you were saying earlier about there appears to be almost no children to children or children to adult.
It is, and it's quite interesting because, for example, with influenza, which is what our public health system was using as their model to start with, the first thing you would think of would be children, because children are big reservoirs and spread influenza everywhere. But in this case, with coronavirus, children seem to be very low transmitters of the virus.
Indeed, yes.
That's all for that slide, unless there are questions. So what sort of things can make it safer when children are returning to school? Or is it safe? We think it is, particularly at the current time where community transmission or community cases of coronavirus are really low. I remember Scott Morrison saying a few weeks ago, saying that the teachers in the staff room were probably at more risk than children at the school. And that probably is true, because it's certainly clear that adult to adult transmission is much more of a risk than child to child or child to adult transmission. So one of the areas that's a risk factor when schools start would be the pick up and drop off areas. So trying to avoid parent to parent and parent to teacher and parent to lots of student contact is important. The education departments have realized that it's really not practical in the school classroom situation to always keep students more than 1.5 meters away from each other. But it's more important to focus on children washing their hands, using hand sanitizers, and also trying to avoid the large gatherings of students together. So assemblies, sporting events, things like that. Lunchtimes when children are congregating around the tuck shop. Part of that, I think, is if there's a big crowd together, there might be more spread if somebody had coronavirus and it was spreading. The other thing would be if we do have a child in a school who has coronavirus and they've just been in their class, they haven't had much contact with everyone in the school, it means the public health system can check up on all of those children in their class, but they don't have to check up on all of the children in the whole school. And that's why some schools may do different things to try to make it as safe as possible. They might consider staggering the play times or the lunch breaks. They might try to spread students out across the school so they don't all go and sit down and eat their lunch in the one place, but they might get one class to go or one year level to go in one area, one in another area. And also that social distancing in the staff rooms, spreading staff out is really important. And I guess the other thing is, you know, the cleaning of the classrooms each day and wiping down of desks in between use. The other thing is just to be aware. Yes.
Can I ask it, because there has been a question, what about shared spaces, you know, shared laptops, shared keyboards? So are we expecting those, should those be cleaned every day as well?
I guess they probably should be cleaned. I think the risks are going to be relatively low, and hand washing is probably really important there as well. The other thing I was going to say is, you know, despite we do all of this, we have low rates of community transmission of the disease. There may be cases, there may be times when a case pops up. And if that's the case, the school would probably close down for a couple of days. They do that deep clean. They check other students, other people who had close contact with those children. They may have to go into quarantine for that 14 days, and the school would open again 2 or 3 days later. And that certainly happened in a few schools in New South Wales over the last couple of months.
Andrew, we've got some very interesting questions coming in actually from some school principals, and I don't know whether we'll be able to answer all of these, and I'll read them out. Should kids be going on school camp? Should there be after school sport? And can schools have open days? Go for your life, Andrew and Vanaja. What do you think?
I'll let you go first, Andrew.
Okay, I guess we've got to follow the statewide rules.
That's right.
And I suppose open days are not going to be on at the moment, because that's more than, I can't remember how many people we're allowed to have outside together. So schools are an exception, but I haven't read it in detail, but I would assume that open days wouldn't fit to that exception.
No.
And particularly because that includes lots of adults coming as well as the children. What were the other ones? After school sports.
After school sport and camps, yeah.
So I think at the moment, after school sports probably are not going to fit into those guidelines. But perhaps after school sports could start with less than 10 people at a time and doing training, but not contact. Some of these things sound a little bit illogical, because we're saying it's okay to do school, but it's not okay to do sport. Doesn't quite add up, but I guess it's just trying to work out what we can do, and also realizing that school is really important for kids, and missing a lot of school is not good for kids as well. So it's weighing up the risks and the benefits.
I think that's a very important point, isn't it? Just, you know, the schooling is such an important thing, an important part of children's life, not just for education, but also their psychological well-being, that social connectedness, and so on. And it might be worthwhile mentioning the study from New Zealand. They had an outbreak in the school. They called it as school outbreak, but in fact, when you trace that back to studies, there was a group gathering. So I think it's important to keep in mind, if there's not a necessary activity, I'm sure the government will guide us through, but if there's not important activity, probably better to avoid it.
And I know we want to talk about grandparents, but there are a couple of really interesting questions. High school students move between classrooms. So should desks be wiped down between classes? What's the current thinking about that? Or if the kids wash their hands as they come into the classroom each time and exit, is that okay?
I think it's about how do we minimize it. And I was thinking about that when I was driving to work today. You know, my child in high school, and they move around between classes. And as you said, the most important thing is hand hygiene, and just making sure you wipe your hands and not touch your faces and so on. If you can do that, that's going to be the most important thing than wiping down in between every child moving between classes. I think that's the best we can do, unless Andrew has anything else to add to it.
Not really. The only thing I had to add is just the importance of school for children. And it's interesting because in my clinics over the last couple of weeks, I've talked to almost every child that I've seen about school and about coronavirus. And if I talked to them 6 months ago, I would bet that about 75% of those kids would have said, I hate school, I wish the holidays were coming. But 100% of, well, not 100%, I had one child who said, school's not good, I get bullied at school. I like it when I don't have to go to school. But every other child I've seen in the last 2 weeks, they said, I can't wait to get back to school. I'm really, really missing school. And the mothers have been even more keen to go back, for the kids to go back to school, I think. But, you know, I think it's, you know,
and look, I'm
really
very aware of the time, and I know we've still got to get to, but there are some two very quick questions, and these are obviously from teachers because I can see their anxiety or their questions coming through. We were saying earlier that we kind of divided up the children, obviously the younger who really aren't getting sick, and then up to 15 years old still as children. If we're saying that children above 15 coming into young adulthood are more likely to act in terms of coronavirus, be more like adults, is that potentially a high risk group? No, Vana, go ahead.
No.
Yeah.
So I guess if you go back to the slide Andrew showed earlier, so if you look at those cases in that young adulthood, they kind of, there are occasional odd people having severe disease in that age group, but vast majority of them under sort of 60 years of age, they don't have severe disease. So that's the first thing. And the second thing is older children can, as you said, behave like adults, not just from the disease presentation, but also hygiene measures too. So they can keep the physical distance. I know it's how hard that would be in the high school, but, you know, at least you can talk to them about that. And hand hygiene, you can talk to them about it. And, you know, sneezing, coughing, and all of that, you can talk to them. So overall, I don't think it's a major issue, even though the presentation is a bit more than a younger age group, but overall it will be, it's not that bad at all.
And Andrew, we have spoken about this earlier. Someone has asked specifically, could we please say whether temperature checks would be a worthwhile precaution or not?
Yeah, look, it's a difficult thing. And I know some places, some countries like temperature checks. We haven't really gone down that route in Australia in saying everyone who comes into a building or wherever gets scanned or has their temperature checked. We've gone down more the road of saying anyone who's got symptoms of fever, cough, cold, runny nose, sore throat should exclude themselves and get tested. So we haven't really gone down that route.
And if you look at the numbers, like only about half of them present with fever. So that might give us a false reassurance. So like if they haven't got the fever, they are fine. So that's another reason I would personally think might not add much value.
Yeah. Can we go to the grandparents, vulnerable adults? Is that okay? We're getting more questions on that.
This was just saying, stay home if you're sick.
So I think this question came to us before, and I know there's a lot of media coverage around this topic, how to best manage interaction with grandparents and others with increased risk. We talked about adults with increased risk of having cardiovascular risk factors or hypertension, heart attacks in the past, or diabetes, and all of that. How do we manage that? So their interaction with children. So going back to children, going back to these adults and grandparents. Obviously, it's up to the family, but the most important thing we need to remember, we have really, really low community transmission rate. And if the outbreaks does occur, then we need to manage it differently. Obviously, if they have significant health condition and they don't want to take any chances, it's fine too. They could avoid the interaction, but the grandparents I've spoken to who bring their children to see us, they take the risk and weigh the benefits and risk, and they say they are happy to bring them. And some of the grandparents might be 50. So it all depends on the actual age of the grandparent, how significant their health condition is, and what their value about what they want to do with their grandchild in the context of not having much community transfer. But the single most important thing of all of these, if the child or anybody got any viral symptoms like a sore throat, cough, runny nose, mild fever, even milder symptoms, just keep them away from the adults, vulnerable adults. And they always remember to keep the hand hygiene going. We can't forget that.
Next slide. Yeah, we might just go on to the next slide. There we go. Andrew, we've literally got 1 minute, so I think we're going to have to wrap up very quickly.
Okay, I just wanted to say it's really important to talk to children about coronavirus. Children hear about it, they're anxious about it, they overhear stuff on the news, on the TV, they hear us talking about it, we've been obsessed, we've been anxious. So I think just encouraging people to talk to their children in the age-appropriate way, but just to be reassuring and help children to understand that, you know, we're in a good spot in this place, but it's still something we have to wash our hands and do stuff about.
Thank you. And finally, we've had quite a few questions come through about a vaccination.
Next slide. Yeah. We can have it on the background.
Vaccination, we hope, but we don't know. There's lots of possibilities, but it's going to be some months away. Keep watching the news every night and they'll tell you when it's here.
Yes, so unbelievably, that's been an hour. So thank you so much to Andrew and Vana. Thank you so much to the participants. Really enjoyed having you on. Hope we got through most of your questions. This is the next webinar coming up on the digital divide. Good night, everyone. And thank you to Vana and Andrew.
Thank you.
Thank you.